Will do.
All right, cool. We're recording, so let's begin. This is workshop number 2 for Strenfest Southwest 2021. We're going to be covering the topic of emergency first aid, which there's a lot to go over. So I'm going to go fast. I am going to pause for questions throughout, and I'm also going to try to have time for questions at the end. If we do start running out of time, I may actually switch to a different Zoom meeting, but I'm going to try to fit it in within our 40-minute time period. So let's get right into it. Starting off with graphic content warning. This is first aid. I'm going to have some pictures in here of injuries and blood. Is anyone going to have a problem with that?
Sir.
I just lost someone. Maybe he had a problem with it. No, I don't know. But let's continue.
Yeah, that was Clint, it looks like.
Dang. Okay. Hopefully he rejoins. Hopefully it was just like a network issue or whatever. Okay. What is emergency first aid? What are we actually talking about here? Obviously, there's a ton that can be involved in first aid, right? What we are specifically talking about when we talk emergency first aid are things that are going to kill you quickly. And by quickly, I mean within the order of minutes. Most things that aren't going to kill you within a few minutes, you'll have time to get to a higher level of care. Even if you're out in the woods or in the backcountry, you'll have time to get out. And so what we mostly focus on are things that will kill you literally within minutes. And there's 2 kinds of things: stopping bleeding and starting breathing. Someone who is bleeding out can die on the order of minutes, and obviously you'll die quickly if you can't breathe either. So these are the things that we mostly focus on. The priority after dealing with those things is mainly about getting the person to a higher level of care. Obviously, you can do other things to try to deal with lesser injuries, making someone comfortable. But for the most part, what I'll be covering in depth in this presentation are those 2 items, and then getting the person out. Does that make sense?
Sure does.
Cool. So why do we actually care about first aid, right? Well, obviously it's because it saves lives, right? But it's important to think about when we talk about the idea of things that kill someone within minutes. That means that if you or someone else does have a critical bleed or can't breathe, there's no one who's going to be able to get there in time to save you. It's your responsibility to deal with it. And so first aid, knowing it is an imperative if you really want to, which hopefully you do, right? Want to save someone's life. I was going to follow up on that with something, but it slipped my mind what it was. So yeah, saving lives, saving your own life, saving others. But of course, we're also talking about this stuff specifically because of the first aid challenge, right? Like that's why we're here. The first aid challenge is going to consist of scenarios, medical scenarios, where you will have to, you'll come upon someone who has a medical emergency. You'll need to identify what that is, and you'll need to handle it appropriately. This presentation will teach you the major steps for how to do that. And it's important to pay close attention to it and to practice this stuff afterwards, because if you don't, you're going to show up not knowing this stuff and you're going to look stupid. So don't do that. There's a lot of acronyms in first aid. Acronyms make things easy to remember, but they can also become overwhelming. So I'm only going to have 2 in here. The first of those acronyms is SAT, S-A-T, and this deals with what you do when you come upon a medical emergency. That stands for first, scene safety, establishing that the scene is safe. Second, accountability, taking stock of what's going on, what's around you, who's involved, and are you the right person to respond to it? And finally, the T is taking command and providing treatment. So actually taking action there. We'll go into each of those in more depth in the next slide, but let's move on to our second acronym, which is MARCH. Has anyone ever heard of MARCH? No, that's fine. MARCH is the set of steps you go through when you're doing this emergency first aid. It focuses on those stopping the bleed and starting the breathe concepts. You'll notice that I've got a second one, the MARHC. The reason for that is the last 2 items are kind of being reordered in the way this is taught. I still call it March, and likely I'm still going to run it in that order, but we'll talk a little bit later about why those 2 things can be reordered. Anyways, what this stands for is M, massive hemorrhage. That's the first thing that you deal with. Airway, making sure the person can breathe, like they even have the ability to breathe in the first place. R, respiration, making sure that even if they can breathe, are they actually breathing? And if not, why not? So getting that breathing going again. And then C is for circulation, and H is for hypothermia. Circulation, it's not just breathing stuff, bleeding stuff. It really refers to making sure that it refers to all the smaller, lower level stuff that isn't going to kill you as quickly. And so it's kind of a catch-all. And then hypothermia is in there because someone who's had an emergency injury like this is at a high risk for shock due to losing body temperature. And so everybody gets treated for hypothermia in the end. We've had a few people join just now, a little bit late. We got started because there's so much information. You'll be able to see the stuff we covered earlier on the video that I post. But I am asking for questions throughout, so feel free to speak up if there's anything you don't understand as we go. I'm next going to move on to SAT. I guess before we do that, let's ask now, does anyone have any immediate questions? No, we're good to go. Cool. We're starting to get into the meat of it, so maybe some more questions will be generated in there. But let's talk about those 3 items that you'll deal with upon coming upon a scene. The first item was scene safety, right? The idea behind scene safety is obviously that as the responder, you have to prioritize your own safety first. So you're making sure the scene is even safe for you to deal with. If this is a car accident, make sure that you're not going to get hit by a car while you're treating the person who's injured. Or imagine you're out in the wood, right, and the patient has been attacked by a bear. You obviously want to make sure the bear is gone and is not going to come back. That's kind of a silly scenario, but it illustrates what we mean by scene safety. Outside of that, it also refers to protecting yourself during the treatment. I have a picture here of someone putting on gloves, right? Anytime you're dealing with an injury that has blood or body fluids, you need to put on gloves to protect yourself in that way. And that's something we're going to be watching for at Strenfest, making sure you put your gloves on first before you deal with a medical scenario. One final item to note in scene safety is that the kind of treatments that you'll be doing can be very painful for the patient. They'll save their lives, but they can be quite painful. And so you need to make very sure the patient is not going to attack you and hurt you while you're providing treatment. And so that might mean looking for weapons the patient is carrying and taking them off the patient before providing aid. That's scene safety. After that is accountability. And what this refers to is looking around, taking stock of the situation. Who is around? Is it just the one victim or are there multiple? Again, if you're coming onto a car accident, how many people were in the car? Similarly, who is available to help you with this? Are there multiple people there? And if there are multiple people there, are you even the right person to be responding to this, or is this better handled by someone else? Important thing to understand about first aid, especially emergency first aid, and this is not legal advice, but I believe it is the case that in most states, you are not legally obligated to render aid if you do not want to, if you do not feel you can. So part of accountability is deciding, do I even involve myself in this? Finally, if you do decide to render aid, the T is take command, become the person in charge, both to make sure that other people know what you're doing, tell other people what to do as well. Like if there's someone else there, a very good thing for you to do is to tell them to get 911 on the phone while you're rendering first aid, but take command. And then of course, provide treatment. That's also the T. That is the SAT acronym. Any questions about that? No, we're good to go. All right, now we're gonna move into the real meat, which is March. We're gonna talk about each of the different steps in there, identifying them and what to do if you encounter it. The M in March is massive hemorrhage. A hemorrhage is a bleed, right? And what we're talking about specifically is an arterial bleed. Those are the kinds that will kill you within minutes. The other kinds of bleed, so like if you hit a vein, that's going to be a lot slower bleeding out. It's not going to be as big a problem, though it's still a problem to deal with, but it won't kill you within minutes. Arterial bleed, however, if you have hit an artery, if it's been punctured, severed, or even just damaged, that's a hose directly from your heart. It will exsanguinate you very quickly. The way to identify an arterial bleed versus a venous or capillary bleed is by what's called, or what is often referred to as spurting, squirting, soaking, or pooling. If you see blood coming out that looks like that, that's a massive hemorrhage and needs to be dealt with. So here's our first graphic picture coming up. Does this look like a massive hemorrhage to you? Obviously, this is a gross wound, but this person does not have blood spurting, squirting, soaking, pooling. They're not in danger of bleeding out. And so you would not treat this as a massive hemorrhage. Instead, a massive hemorrhage is going to look something more like this. This patient obviously is losing a lot of blood. That's obviously pooling. And so if you see this, you know that that patient is in real danger of losing their life very quickly, and you need to act. This all being said, you may encounter a scenario where it's hard to tell whether there's a massive hemorrhage. Maybe it's dark. Maybe the patient is in a weird position where you can't see the blood. And so in addition to just looking for this, you need to perform what's called a blood sweep. A blood sweep is literally taking your hands, you've got gloves on, taking your hands and moving them over the patient's body, looking for blood. It looks like everyone's sitting down. I want you to take your hands right now, both of them, put them up near your knee, and then run your hands down your knee. Get some real pressure on there, like you're trying to give yourself a massage. That's what it should feel like to do a blood sweep. You're trying to not just, get blood on the surface, but push blood out if there is some coming out. After you've done that, you'll take your hands, put them up, look at them, look for blood, pinch them, roll your fingers around, feel for blood. And then you'll do that in little chunks all over the body, looking for blood coming out. That's another way to identify the massive hemorrhage. And again, if you're doing first aid at night or in a low light scenario, that's required to truly find this stuff.
Hey, Garrett, real quick. It was squirting, soaking, pooling, and what was the last one? Sorry, I missed.
Spurting. Squirting, spurting, soaking, and pooling. All right. So you've identified a massive hemorrhage. How do we treat it? It's going to depend on where it is. If it's on a limb, so your arm or your leg, you treat it with a tourniquet. The idea being that you're going to occlude the blood vessels, block the blood vessel, pinch it off so that blood can't come out anymore. Because we're all strenuous life people, we've hopefully put on tourniquets before in one of our agons. But the general idea is to take the tourniquet, put it on the affected limb as high as you can do it. This picture, it's too low. This is actually a bad application of a tourniquet. It should be much higher, all the way up on top of the arm. So you put it up high and then you make it tight. You tighten the thing as much as you can. You secure it. In this case, there's Velcro that allows you to secure it. And then you crank down on that windlass, that stick on top of the tourniquet. You crank down on that and turn it until the bleeding stops. That's tourniquet application. After that bleeding has stopped, you secure the windlass. You secure the whole thing, sort of make sure it's not going to come loose. High and tight is the name of the game for tourniquets.
Hey, Garrett, on practicing that, I've seen you guys talk about practicing that like you would really do it. And I mean, do you go all the way where you feel the pain like deeply and you would do it just like you would a real tourniquet when you practice?
It's a good question. When I practice it myself, I will turn it 3 or 4 times, which is enough usually to make it appears to me that the blood has actually stopped in that arm, which is how far you would do. That is a painful thing to do. And you will get bruising from it, but that's how I practice it myself. Now, I have heard in reality that you need to crank that tourniquet even more than that in an actual scenario. So, maybe you do need to go further. But
yeah, until you don't see any more spurting or any more blood, right?
Exactly. So I'm not telling you when you practice this stuff and when we do this at Strenfest to get it so tight that it's really painful for your guy. But a proper tourniquet application in practice should hurt a little bit and it should leave some marks behind. That's my opinion.
Okay, thanks.
No worries. Any other questions about tourniquets?
Do they make like a tourniquet dummy like they do for CPR?
Kind of. There is a thing that I've seen which is used for bleeding practice, where it's just got like a little tube going through it. It's like a fake arm and it's got a tube going through it. And I guess you could use that as a tourniquet thing. Those are often more used for things like wound packing, which is actually what we're going to talk about next. But I suppose in most cases when you're doing tourniquets, you just do it on yourself or on someone else. All right.
I guess for the purpose of seeing how far you have to tighten
it. There probably is things there, but again, when you're doing it on yourself, you'll be able to see, you can check your pulse and see there's no pulse coming. You can pinch your arm and see that, hey, it doesn't refill with blood. Like the blood is pretty well cut off. You'll get to see that at Strenfest as well if you've never gotten the chance to do this. So tourniquets are useful or not necessary, right, for wounds on the arms and legs. But if it's not there, if it's instead somewhere else, the chest, the pelvis, the neck, the groin, what you do instead is called wound packing. There it is. The idea with wound packing is literally, I can't tourniquet this. So instead, I'm just going to shove as much gauze into that wound as I can. I'm going to fill it up as much as I possibly can, put pressure in there, create a clot, and stop the blood that way. You're literally shoving the gauze in until you either completely fill that wound and can't fill it up anymore, or you run out of gauze. And in most cases, you're going to run out of gauze first. This wound packing obviously is very uncomfortable for the patient. Putting a tourniquet on is uncomfortable as well. So that's what we talked earlier about, making sure that the patient does not have any weapons or is not able to effectively hurt you, because this is the kind of thing that can cause quite a reaction. While you're doing this, you'll be talking to your patient, right, and trying to keep them calm, letting them know what you're doing and that it's going to hurt, but it will save their lives. That's massive hemorrhage. Is there any question about that? Cool.
No, but I do have a question from earlier, like on the very, very beginning.
Okay.
Every first aid class I've taken has talked about obtaining consent. Do you think you have to? I mean, when you're in a situation like this, do you try to obtain consent, or do you just move?
That's a very good question, and maybe I should have mentioned that I'm not covering things like laws too much or things of that nature in this presentation. But my quick answer to that is that it's really going to be contextual, right? If the patient is, unconscious, then you have to make a decision whether you involve yourself or not. We talked earlier about how there's no obligation to render aid. If they are conscious, maybe you do, when you come upon them, say like, hey, I can help you with your injury. You're going to die unless I help you. Is that okay? Or maybe you just start working, and if they accept it, cool. If they don't, if they start telling you no, you can certainly stop if they tell you that, but it's really contextual.
Thanks.
That's maybe the best thing I can say about that. All right, let's move on to Airway. Unlike massive hemorrhage, Airway is pretty simple, fortunately. The idea is simply to ensure that the patient has a clear airway and is physically able to breathe. There's nothing blocking them. If that patient is conscious, then it should be pretty obvious, right? They'll tell you if they're choking. They'll make it pretty obvious, or at least they should. If they are unconscious, however, you need to check yourself. And the way you do that is by what's called this head tilt chin lift. You're putting your hand on the person's forehead and sort of pushing down. You're putting your other hand on the chin and sort of pulling it, opening it up, trying to straighten the airway out and open the mouth up so you can then literally look inside. And what you're looking for is simply, does this look like a normal mouth? Can I see the tongue? Can I see the teeth? Or is there something gone wrong here? Is there a mechanism for them to have something stuck in their throat? Or can I actually see the thing in the throat, right? If you can, there's mechanisms to obviously get it out. Obviously, there's the Heimlich maneuver to remove a choking object. You can also just stick your fingers in there and try to pull something out. There's less fancy stuff around clearing the airway. It's pretty simple and brutal, right? Just getting that airway clear so the patient can physically breathe. Any questions about that? Cool. Getting back into more complicated things, which is the third step, respiration. And now we've confirmed that the patient has no blockage, so they should be able to breathe. So are they in fact breathing? The way we check this is with a technique shown here, where you're going to put your hand on the patient's chest. You're going to get down low and look down the chest, and you're going to get your face close to their nose and mouth. What you're doing is feeling for the rise and fall of the chest with your hand. You're looking to see if you can see the chest moving, and you're also trying to feel if there's any breath coming out of the nose or the mouth. If you feel breathing, that's good. The patient is at least breathing. They're not totally breathless. Don't worry too much about, how quickly are they breathing. That's something to be dealt with later. Just for now, establish that there is breathing going on. If there is not breathing going on, the next step, if you choose to perform it, is CPR. I think most people know what CPR is, so I'm not going to go into that one. But if they are at least breathing, then that's good. That's the first step of respiration. Just because a patient is breathing does not mean that everything is okay. There are certain things that can impede breathing. The one that we're going to cover, the most dangerous one, is what's called a sucking chest wound, or the actual medical term, tension pneumothorax. The idea behind a sucking chest wound is that there's a puncture to the chest. You've punctured the abdominal cavity. Inside the abdominal cavity is a vacuum, but if there's a hole in it, air is able to get in. And a tension pneumothorax occurs when air can get in, but it can't get out. When that happens, the chest fills up with air, the pressure starts to build up, the organs start to collapse, especially the lungs. And so as this happens, the patient becomes unable to breathe. And this is something that people can die from. In fact, they do die from. And the reason we're concerned about it is because it's really easy to pick up one of these chest wounds, right? So we need to know how to deal with it. The way that you'll start to identify this is if the patient begins to have more and more trouble breathing as time goes on. If that happens, that's a clear sign of there being a sucking chest wound. But of course, before we even look for that, we'll normally just perform a sweep to look for these wounds, even if the patient seems to be breathing normally. The way that we're going to do that, just like with the blood sweep, we're going to use our hands to move over the chest. You're actually going to pull the skin apart with your fingers, like you're trying to almost, dig your fingers in there and tear it. Not that hard, obviously, but you're going to pull it apart to look for these wounds. The reason being that they can be very hard to find, especially if they're in something like an armpit or somewhere like that. It's not easy to spot them. And so you're going to do that all over the front of the chest, below the collarbone, above the belly button. You're going to do it along their sides. You're going to do it on their back. You're going to do it everywhere, looking for these sorts of wounds. If you do find one, the way we treat it is actually dumb simple. All you're doing is putting a chest seal on it. A chest seal is simply a sticker that sticks on the chest and covers the wound up. It stops the air from getting in. And that's literally all you do to treat a sucking chest wound. The last thing I'll mention about this is there's a phrase, which is that if there's one, there's two. Obviously, if there's a penetrating chest trauma, there's a mechanism not just for one injury, but the second one, right, going out the back. And so if you find one, you're going to look real hard for that second one. And if you find two, you're going to look real hard for four, and so on. Does that all make sense? And are there any questions?
If you, let's say you encountered a person and they're not having trouble breathing right now, like, would you always search for a sucking chest wound anyway? Or
I would. Yes, I would.
Decide to do that.
How would I do? I always would do it, especially if the patient is unconscious. If they are conscious, unless they get like really upset about you taking their shirt off, right? Then I do it. You definitely do it if there's mechanism for that injury. Like if you know the patient has been injured in the chest, then yeah, do it 100%. But just generally, there's not much of a reason not to do it. So I would.
Real quick, Garrett, can you explain why if there's one, there's probably two? I just kind of wasn't understanding that. Could you go over that again real quick? Sorry.
Sure, man. So the kinds of things that will cause these wounds, right, are like a gunshot, being stabbed, being impaled by something, right? Obviously, if there's a gunshot, the bullet is likely going to go through the body and then it's going to come out the back. And so there's a mechanism for two.
Understood.
Yeah,
Got it.
That's why. All right. And actually kind of on that subject, I want to briefly digress onto impalement specifically. This is something you guys may have heard, but if you come upon someone who has an impalement injury, obviously this photo shows someone who's got a big stake through them. But this can also refer to someone with a knife stab wound, right? If the object is still in place, the idea is to leave it there. Do not try to remove it, even though the patient may want you to remove it, even though it may seem like you really should. The reason being that the impaled object may be preventing a massive hemorrhage from occurring. If you have a knife in the leg, it may be blocking the vessel, and taking it out may cause that critical hemorrhage to happen. So leave it in place. Don't make things any worse. Work around it. And you can work around it. You can put chest seals around impaled objects. You can put gauze around impaled objects and secure them. In fact, you should secure the object for transport. But the major thing to understand is to not try to take it out, even though that may be the temptation of the instinct. Any questions about that? Cool. All right. We have gotten through the things that will kill you quickly. We've dealt with stopping a massive hemorrhage and getting breathing going again. So the remainder of March deals with kind of the wrap up and the stabilization. What that means is that you will now have a lot more time to deal with things. You can calm down a bit. You can take things a little bit slower. I talked earlier about circulation being kind of a catch-all. So circulation pretty much refers to everything else that you can come across. So this involves cuts, burns, sprains, stings, head injury, things like nausea, diarrhea, broken bones. There's all sorts of stuff that gets treated in circulation once the major important things have happened. I'm going to go into pretty much none of these because a lot of these, you already know you know how to deal with a cut. You probably know how to deal with a sprain. And if you don't, you should learn that. But I am going to talk about broken bones because that one is maybe a little bit more advanced and it deals with splinting. I think you guys probably know what splinting is, but the idea behind splinting, of course, is taking a rigid object and securing it to the body or to the broken limb in order to prevent the user from moving it around and making the break any worse. This is especially important if you need to transport the patient. I'll actually start by noting that if you're in a scenario where emergency services can get to the patient, I probably wouldn't splint as long as you can keep the patient still. Like if you're just like at your house and you've broken your arm, like just hang out and wait for emergency services to come and deal with it. Like don't try to mess with it yourself. But if you are in a scenario where you're out in the woods, say, or you need to move the patient in some manner, then splinting becomes appropriate, and that's when you would do it. You can see in this splint that there's, in addition to the stick and the thing securing it to the legs, the wraps, they've also got this thing with the come along at the end. That's weird. I guess that's like to create traction or whatever. That's not normal for a splint, so try to ignore that. In fact, let's cover it up and let's talk about just the theory of splinting generally. And by the way, I just got the 10-minute notification. We are going to run over time. So when we hit 5 minutes, I am going to try to create a new Zoom room for you guys. But let's finish the broken bones thing first. The mechanism for splinting is to secure, ideally in 6 different places, which are above and below where the fracture is. And then you're going to find the joint above that and the joint below that and secure above and below each of those joints. So that's 6 places. So in the left scenario, right, it's the arm. We're imagining a splint. I guess I've drawn the splint like right on the elbow, but let's pretend that the splint is like on the forearm. So you'd the break is on the forearm. You'd splint right above and below that break. Then you'd splint the wrist and you'd splint the elbow, is the idea. Obviously that picture shows fewer locations like that, which again is something kind of weird about the picture, but that's the ideal splinting. Is there any questions about that one? Okay, cool. What do I have next before we go on to this one? Hypothermia, which is the last one. So let's go over this one before we do the new one. I'm happy on this one that I finally get to get away from using medical pictures and can instead use a picture from the last Strenfest. That's Abe in an emergency blanket. The idea behind hypothermia, like I said before, is that if you have one of these critical injuries, the patient is now at a mechanism for losing body temperature, and so needs to be kept warm, because if they're not, they can go into what's called shock. Fortunately, this is a pretty simple thing to deal with. You simply keep the patient warm as best you can. Putting them under a blanket like this emergency blanket is one way to do that. You'll also want to get them off the ground if you can. It may seem odd to talk about hypothermia in things like, outside of cold scenarios. Like if we think of hypothermia occurring, say, in the snow, but in reality, it can occur on any day so long as the ambient temperature is less than body temperature. Even if it's like an 80-degree day, a person can still get hypothermia if there's the mechanism for it. And so that's why we always treat for it, no matter what the injury is, no matter what the conditions are. Does that make sense? Cool. You'll recall at the beginning that we were talking about the H and the C in March kind of being rearranged. The new idea is that there's really no reason not to treat them for hypothermia before dealing with circulation. Like, why not just get the blanket on them before starting to deal with the other injuries? Which, that's fair. That makes sense to me. Personally, I think that you just sort of treat it as a case-by-case basis, but that was the idea behind that one.